Good afternoon. I'm Dr. Gilbert Florentino, and we will talk about cardiac implantable devices. Who gets what, when, and for how long. I'll be covering the following devices: pacemakers, implantable cardioverter defibrillator (ICD), cardiac resynchronization therapy (CRT), implantable loop recorders (ILRs), and the indication using the 2021 ESC guideline for pacing, and the AHA 2017 guideline for ICD as well. So pacemakers, they are electronic devices that generate impulse, or sometimes they're called pulse generators, to produce heartbeat. And they're primarily used to treat bradyarrhythmias, or bradycardia, with a mechanism of maybe one of the following: failure of impulse generation formation or failure of impulse conduction propagation. Let's review the basic electrical conduction system of the heart. In a normal situation, we produce our own heartbeat, and it takes place in our SA node, atrial node. It usually discharges at the rate of 60 to 100, and it polarizes the atrium, it is in the P wave in your ECG, and conducts to the AV node, down to the His bundle to the Purkinje fibers. AV node also can discharge impulse at the rate of 40 to 60. And same thing with Purkinje fibers as a slow rate at the rate of 20 to 40. Once the SA node is diseased, for example, or there's a conduction block or impulse generation, the AV node will surface and takes over the electrical conduction system as escape rhythm. And that also happens as well with Purkinje fibers the moment the AV node have a conduction block or conduction abnormality. And that occurs, the SA node, the atria, to be specific, and the ventricle totally dissociated. So bradyarrhythmias can be simply divided into two. Can be a sinusoid dysfunction from the disease SA node, can be AV block from the AV node. This also covers the increation block as well. For sinusoid dysfunction, it's very important to determine its causes. It can be intrinsic, can be extrinsic, and can be reversible as well. So I prepared some ECG showing some sinus pause, 3 seconds, patient complaining of syncope, a longer sinus pause, 4 to 6 seconds, and a patient may complain of tachycardia, palpitation, at the same time with history of dizziness and syncope. And usually we consider this as a bradytachycardia syndrome. They usually require medication for rate controllers, but we are afraid to optimize their medication because of the risk of bradycardia or syncope attacks. And they should require pacing as well. Another ECG showing junctional rhythm of a previously sinus patient, no history AF, with history of dizziness and generous body weakness. So the guidelines tells us that after all our workups done and proving that the bradyarrhythmia, bradycardia is secondary to sinusoid dysfunction, then it's a class 1 indication to implant pacemaker. And what type of pacemaker they usually benefit? They recommend a dual chamber pacemaker for sinusoid dysfunction. So, properties that they benefit from prevention of atrial fibrillation. That's number one. Number two, the risk of developing AV block in the future. And we tend to minimize ventricular pacing as well. And the reason why we want to avoid as much as possible ventricular pacing in an intact AV node because of the risk of AF. So, and if you're considering single chamber pacemaker, we don't usually put that in the atria anymore because of the same reason. We usually put that in the ventricle. But we need to stratify our patient very carefully. If we, the one that will require ventricular pacing are those with uh, intermittent or paroxysmal sinus sponsors, as compared to a permanent uh, uh, facial intelligence function. So they will definitely benefit with a dual chamber. Okay. How about the bradykardia tachycardia? Bradycardia tachycardia syndrome form of sinus node dysfunction. This type of patient usually require medication for tachycardia. And in order for us to optimize that medication, we need to we need the pacing medication for bradycardia. So, and that's why this type of patient are necessary drug therapy. Will require necessary drug therapy for patient. Okay. Of course, it's not recommended for sinusoid dysfunction, which are asymptomatic with reversible process. How about AV blocks? Under AV block, we have first degree AV block, PR interval. We have second degree AV block, prolonged PR interval followed by drop beat. You have a second degree AV block type 2. You have a fixed PR interval followed by a drop beat. And we have 2 to 1 AV block and hydrate AV block as well. And the last was the third degree AV block. But we don't implant pacemaker for first degree and second degree COVID type 1. Only the remaining type of AV block will require pacemaker irrespective of their symptoms. So again, I prepared some examples of second degree AV block type 2. There's a drop beat, the arrow. At the drop beat, the PR interval is fixed. And here, ECG of a high-grade AV block. Again, I just want to show you that there are no dissociation, that QRS complexes are conducted beat. They are not escape beats. They are not escape beats. As compared to your complete heart block, the P interval this time varies, and the QRS, this ECG is on skip rhythm. So they are totally, the atria and the ventricle are totally dissociated. How about AF with AV block? So same thing. Patient with atrial fibrillation, irregular before, complaining of dizziness and syncope. And then you have a 12 ECG of like this. So there's only one interpretation. Patient develop complete heart block. So there's a complete dissociation of the atria and the ventricle. So no P wave because of the atrial fibrillation, and you have a skip ventricular rhythm. Your QRS. In this form is LB 145. So the guidelines tell us that whether you're sinus rhythm or AF with AV block, okay, so either third degree, second degree, type 2 or 2 to 1, or high grade AV block will require a pacemaker. And of course, we don't pacemaker with reversible process. Okay. And some unexplained syncope with biphasic block will require a pacemaker. Or even if you are undergoing an electrophysiology study with evidence of prolonged HV interval more than 70, or during incremental atrial pacing, with documented AV block, or abnormal response to pharmacological challenge, then it will require pacemaker. A patient with alternating bundle branch block, with or without symptoms, of course, will require a pacemaker because of the okay. And of course, we don't put pacemaker with asymptomatic block or biphasic block. Okay. How about implantable loop recorders? They are very small device, maybe 2.5 inches in length. Can be implanted into the subcutaneous tissue in less than 30 minutes. Can be outpatient, and they usually require uh, uh, not so technical, and these are indicated for patients with infrequent symptoms, very infrequent symptoms. Unfortunately, in our current setting, we have only 24-hour or 14 hours loop recorders, Holters, and they usually are limited in the time frame. Unfortunately, if patients having symptoms not so common, not so frequent, it's very hard to document. Okay? It's hard to capture if their symptoms is related to bradyarrhythmia or bradycardia. So loop recorders usually has a battery life of can can last for 3 years, yeah? And hoping that within that time period, at least one episode can be documented in the time frame. Yeah? And these are usually indicated again for our patient with very infrequent, less than a month, yeah, with unexplained syncope, for example, or other symptoms of bradycardia. Uh, we already exhausted all our comprehensive evaluation, but didn't demonstrate or didn't document any particular cause or documented any cause of bradycardia, bradyarrhythmia. So that's why this type of patient will require a loop recording. So after 3 years of, for example, but the battery ran out already, no need to explant that loop recorder. So we don't leave them touch it anymore. We leave it there. We don't want to put them at risk of getting infected. So how about implantable cardioverter defibrillator (ICD)? So I have a picture of external defibrillator as compared to your implantable cardioverter defibrillator. Very small. They're both used to treat ventricular arrhythmias, yeah? And that is because of the risk of sudden cardiac death. And ventricular arrhythmias can be in ventricular fibrillation, which we don't require to check for vital signs or even check for pulse. We require immediate defibrillation. And on the other hand, we have ventricular tachycardia, stable, unstable. So the risk of sudden cardiac death is the main reason why we're talking about ICD, and the single most risk factor for sudden cardiac death is a very low ejection fraction, which is 35 in this specific. And we have two indications can fall under primary prevention or secondary prevention. So simply to say under primary prevention, uh, there's no event yet. Patient didn't go to cardiac arrest or no evidence of ventricular arrhythmias or the VT. So in secondary prevention, on the other hand, there's also they already suffer from arrest, yeah? And if they are lucky and successfully restated from VTVF, then they fall under the category of secondary prevention. But some of them they will not make it. That's why the population for primary prevention is larger, bigger than secondary prevention. So how to reduce the sudden cardiac death for our patient? So that's why we have here a basic, simplified chart. So again, we have patient with low ejection fraction 35 with the risk of sudden cardiac death. With cardiomyopathy can be ischemic or non-ischemic. For ischemic cardiomyopathy, we can stratify them as without revascularization or medical management only, no intervention. And the waiting period is 40 days for primary prevention. For those patients with ischemic cardiomyopathy who underwent complete revascularization, whether angioplasty or bypass, will require a waiting period of 90 days before evaluating for ICD for primary prevention. And for non-ischemic cardiomyopathy with class 2, class 3 AYHH classification, and the remaining cardiomyopathies will require a 90-day period as well, waiting period to evaluate if they're a good candidate for ICD prevention, for primary ICD implementation. So during that period, we need to optimize guideline-directed medical therapy. And it includes your beta blockers, your ACE, ARB, and your MRAs. So again, and then we evaluate them after the designated time frame. or the ejection fraction if they improve or not. So that's the primary reason why there's a waiting period. So they might improve. The ejection fraction may improve after that period, given time. But for those patients during this waiting period who will suffer from ventricular arrhythmias, will definitely fulfill the criteria for secondary prevention. There's no need to wait for that time frame anymore. So that will change the indication. But since I mentioned a while ago that the primary prevention population are larger than the secondary prevention population, some experts, a group of doctors want to stratify further additional risk factors that is almost equivalent to a risk for sudden cardiac death for secondary prevention. And they're considering some of the following risk factors: a very low ejection fraction, post-MI, episode of non-sustained, documented non-sustained VTs, very frequent PVCs, or even undocumented syncope after syncope. Again, these are for primary prevention. So in summary, so as long as there are no reversible causes for secondary prevention or suffer from ventricular fibrillation who survive cardiac arrest, patient is automatically a candidate for ICD implantation. Patient who documented hemodynamically unstable VTs or VT with syncope with a very low ejection fraction, of course, they will put it there for ICD implantation. So for primary prevention, again, for ischemic cardiomyopathy without intervention or revascularization or incomplete revas, 40 days is a waiting period. Okay, with low ejection fraction 35, as it is indicated. For complete revascularization, whether angioplasty or bypass, at least 90 days waiting period before considering ICD if they remain low ejection fraction or even lower ejection fraction after 90 days. For non-ischemic cardiomyopathy, waiting period 90 days after optimized medical management. If they remain low ejection fraction, they are candidate for ICD implantation. How about CRT or cardiac resynchronization therapy? So keyword is to resynchronize, and the problem here is desynchrony. And desynchrony is simply say as uncoordinated regional myocardial contraction or depolarization. So we have two mechanisms: the electrical and the mechanical desynchrony. So under electrical desynchrony, there is a conduction delay. The primary reason why there is a non-uniform timing of myocyte depolarization, and this is best represented by left bundle branch block in your ECG. And the primary mechanical desynchrony, on the other hand, are regional delay, such as shortening and time to peak shortening of LV segments, region ischemic fibrosis, and usually these are documented using 2D echo or sometimes cardiac MRI. But unfortunately, in CRT criteria to who will benefit for CRT, we usually use the electrical desynchrony or the ECG for LVDD. And the reason why, because there are a lot of variation or different interpretation measurement for mechanical desynchrony. So I have here a picture of what LV desynchrony looks like. So you can see the ununiform or unequal mechanical contraction or electrical deposition as well of the LV, causing a delay contraction of the muscle, which will worsen the mitral regurgitation and worsen heart failure as well. So because of this desynchrony, we, by by resynchronizing the LV, we can we can minimize the mitral regurgitation by restoring the uniform contraction and depolarization of the left ventricle. And that's the primary reason why we need to resynchronize the left ventricle. How about the right bundle branch block? There are very limited evidence show that they will benefit for CRT, and even the experts are debating about the benefit of CRT for right bundle branch block. So to date, LBVV or left bundle branch block will definitely a good candidate for CRT as compared to right bundle branch block. And even there are good candidates for CRT, not all left bundle branch block will be a good responder. Uh, the reason for this is because there are a lot of factors to consider. Um, Female non-ischemic are usually they are good responders. Male non-ischemic are usually non-responders. But again, it's not limited to that alone. There are a lot of factors to consider as well. Okay. So again, I prepare a ECG showing you a very wide left bundle bunch block. It's more than 150 milliseconds. Actually, this is a trifascicular block. And eventually, this patient underwent CRT implantation. And I'm showing you a chest X-ray of a complete system of CRT, the pulse generator, the typical right atrial lead, the RV ICD. You can see the coil there, the ICD, and you have the CS lead or the LV lead. Okay. So the current guidelines tells us that it's a class 1 indication for number one, sinus rhythm with a very low ejection fraction of 35 and a very wide QRS of more than 150 milliseconds and left bundle bunch block morphology. Okay. So, and of course, it is not indicated for less than 130 okay, duration and without RB pacing. That means that you need to you need RB pacing for AB block to consider uh, uh, regardless of the QRS duration. Okay. So that's the only message there. So as long as without RB pacing, then you need to wait for a wider QRS. In symptomatic atrial fibrillation of uncontrolled heart rate, for example, and considering AV node ablation or to induce AV block, then regardless of the QRS duration, CRT is recommended as class 1. So, and we mentioned this already, CRT rather than RB pacing is recommended for low EF, regardless of heart classification, who have an indication for ventricular pacing and AV block. So the moment you have an RB pacing indication, it's automatically a good candidate for RT pacing. And those patients with ICD indication, of course, CRTD is recommended. Okay. Okay. That ends my slide. Thank you. So in summary, we discussed about overview of the what are pacemakers and the sinus dysfunction and the AV block, the primary indication for the pacemakers. Loop recorders for not so frequent symptoms of bradycardia documented. We need a longer recording for that one, documentation. And ICDs, of course, discussing between the secondary and primary prevention for protecting our patients from sudden cardiac death. And those patients, we criteria for CRT, specifically for left bundle branch block morphology. So again, I thank you and enjoy the rest of the afternoon.